Okay, great. We've got a terrific panel. They're all expert knee surgeons, and what we're going to do for the next 21 minutes is talk about key decisions in the perioperative and intraoperative management of the total knee arthroplasty patient. Many of you who have been here in the past will have heard me conduct this session previously. And what I'll tell you is interesting about it is that while I ask some of the same questions and some new ones every year, the answers are always changing. Why is that? Because practice is always evolving. So use this as an opportunity for yourselves to ask yourself a question. Am I within the boundaries of what these experts are doing? They're not all going to have the same opinion, but you're going to get an idea of the boundaries. And you're going to get an idea of what is standard practice nowadays and what has fallen aside and what is coming on as a new way of doing things. And so with that, we'll get going with the panel. Panelists, I will ask some of you a question in every case, some of you a question in certain cases, and I'll ask all of you to be concise with your answers because we've got about 30 or 32 questions to get through in just 20 minutes. So quick answers, and with that, let's get started. My disclosures are as listed. I receive royalties from DePuy on some hip and knee products. Preoperative decision making. Body mass index. Do you have a strict cutoff for whom you'll operate on, and if so, what is it? Starting with Sanjeev. I have no cutoff. No cutoff. You'll operate no matter what, and you won't make them lose weight. Okay? Prakash?
Actually, no cutoff. Basically, the physiological quality of the bone and the activity preoperative.
Okay?
40 is my cutoff.
40 is a cutoff. Is that a hard cutoff for you?
40, 42 I would not stretch it to 45. I mean. 40.
So you'll be a little flexible in the low 40s, but if they get really heavy, you're going to say lose weight first.
Absolutely.
Thanks, Ashok. Raj?
No cutoff.
No cutoff. Arun?
I discuss with the patient and explain to them the risks of very high BMI.
Yeah.
Get them to lose weight if they want to, if they can. If they say no, we can't, then I go ahead, provided I can flex the knee.
Okay, so you'll have some sort of look at the tissue envelope. Parag?
40 is my cutoff. Anything more than 40, I talk them into do a bariatric surgery.
Okay, Alpesh?
40 is the cutoff, but we have to discuss the morbidities and complications associated with the knee replacement, post-knee replacement.
Fair enough. So it sounds as though roughly half the panelists have no cutoff, roughly half of them have a sort of soft or medium hard cutoff at around 40. And everybody, the main thing, of course, everyone's concerned about is infection. That's the big differentiator based on body mass index. I'm going to ask for a one-word answer here. Smoking. Do you allow patients who are smoking to have a total knee or not? Yes or no, starting with Alpesh.
Smoking, we just check the vascular status. If there is a vascular problem, then we have to tell them that you have to first get the vascular problem corrected. And we recommend them to stop the smoking because of the wound complications that can happen.
Okay, Alpesh, I wasn't counting, but that was definitely more than one word. Parag.
So strictly tell them not to smoke. What they do is another story.
Okay, you asked them not to. Yeah.
No.
I asked them not to, but it doesn't occur that way.
Arun, was your no a no you don't care, or no they can't have it?
I don't care.
You don't care. Okay.
Always. Always.
Stop. Okay.
Yeah, we'll ask them to stop, but if not, at least 4 weeks preoperatively.
Okay, that's an important point. That's probably the biggest risk is smoking in the perioperative period. The long-term smoking issue is a little harder to solve. Sanjeev?
You ask them to stop 4 weeks prior, but they don't stop. Chronic smoker, they never stop.
So if they don't stop and you know they didn't stop, will you still do the surgery?
No, you need to tell them the risk and then.
Okay, but you'll still go ahead. Nutritional assessment. Does anybody do any specific nutritional testing routinely on all of their patients? Raise your hand if you do that. Oh, so quite a few of you do it. Okay, so let me ask Ashok, what do you do and why?
I look at the albumin status.
Okay.
And I also look at the hemoglobin.
Okay, does anybody else do anything different? Total lymphocyte count, anything else? Transferrin? No?
So the AG ratio, the proteins, what Dr. Ashok Rajgopal said, we'll look at if it is low, we need to supplement it.
Okay, Raj, you were going to say something?
Yeah, total leukocyte count, always have a look at
total
that.
Total leukocyte count?
From the infection point of view.
So will you check it on every patient?
Yeah, I think that counts.
Okay, fair enough. And for me, I've usually kind of done the eyeball test, and if I'm worried, then we start doing more testing. Diabetes patients, quite a few here. Hemoglobin A1C testing, do you do it? How many people do it? Yes or no? Yes? Okay. And what's your cutoff? Is it around 7 to 8?
7.5 HbA1c, we have a cutoff, but we extend it up to 8.
Okay, anybody much different than that?
More than 10 is a strict no. I'll try and get it down. Up to 10 I will take.
So you'll go ahead even if they're a little bit higher. Most of the data shows that hemoglobin A1C does not correlate very well in orthopedic surgery with postoperative infection risk. Perioperative blood sugar management, however, does. So if a patient's poorly controlled, you can assume they'll have poor perioperative blood sugar management, so it's a good idea to control them. This is an area where there have been a lot of changes recently. Preoperative urinalysis. How many of you routinely get it on every single patient? Most, but not all of you. And if you have a positive urinalysis, how many of you will go ahead and treat the patient and go ahead with surgery within the next few days?
So if they are diabetic and they have a chronic UTI, I will go ahead.
You'll go ahead if it's a chronic UTI.
No, if there's a documented UTI, we will treat the UTI first because it's one of the most common factor for causing post-operative infections.
Okay, that's an interesting point, although it's actually been hard to prove. Yes, Ashok?
Symptomatic UTI, I would treat.
Yeah.
Asymptomatic bacteriuria.
You do not. Will you give them an antibiotic anyway?
Yes, we would.
An antibiotic, but you'll go ahead.
Yeah.
Raj?
I would treat them and wait till the urine becomes negative.
Okay, so you want to treat?
I want.
Okay, Arun?
1 lakh count, colony count or more, I treat them. And then after their course of antibiotics, whatever the duration, then I would operate on them.
Parag?
If the urine does show pusses, I'll wait for 2 days, I'll get a culture, and if the culture grows something, I'll treat them. Otherwise, I don't care for the urine pus cells which are seen, because sometimes it's a wrong report.
Alpesh?
If that is asymptomatic urine infection, nothing doing. If it is symptomatic, then get a culture done, treat it, and then go ahead.
Okay, thanks. And this is an area where in North America the practice has changed quite a bit. Most surgeons are no longer getting a urinalysis routinely on patients before total knee or total hip replacement. If patients are symptomatic or there's some reason to be particularly concerned, they are, but most people have abandoned routine urinalysis in North America. Standard antibiotic prophylaxis. How many of you routinely use a first-generation cephalosporin as your standard antibiotic prophylaxis? How many of you use something else? Okay, Arun and Rajesh, you both raised your hands. What are you doing differently?
It's a second generation
Cephalosporin?
cephalosporin, 3 doses.
Why a second generation cephalosporin when it has poor Staph aureus?
Second or third, I think it was established at our hospital by the ICU chief, the infection control, and that's what we followed.
Okay, fair enough. Arun?
The other problem is cefazolin is not available.
Oh, you can't get it? Unbelievable. It's cheaper and better. Okay, we won't fight about it. Antibiotics and cement. If you are cementing an implant, will you use routinely antibiotics in the cement only in a high-risk patient or never? Let's start with Alpesh and go down the panel, but quick answers, please.
In primary TKA, we don't use antibiotic impregnated cement even in high risk. If it is a revision, then only we use antibiotic.
Okay.
Antibiotics for everyone.
You give it to everybody.
Yes.
So quite different answers there. Arun?
High risk only.
High risk only. Rajesh?
Everyone.
Everyone. I like you two guys' succinctness. Thank you. That's great. Ashok, everybody else take note.
High risk.
High risk
For everyone.
for everybody.
Only in 2-stage infected infection.
So, you see, you got exactly no consensus there. But I think everybody said they would do it in high risk, at least. Is that right? So for sure in high risk, the rest of the patients, you decide. Tranexamic acid, is everybody using it? Hands up if you are. Yep. Only 2 of you are not. Oh, you are? Yeah. Okay.
Depends upon the high risk group of the patient. If it is more thrombotic, then I would like to avoid.
You're a little afraid of it, huh? Okay. And do any of the rest of you have any exclusions? Most surgeons in North America have now gone to giving it to absolutely everyone with very little concern about the risk of patients who've had a previous thromboembolic event. Is that consistent with most of your practices? Yes, Ashok, yes. Parag, I see you're shaking heads. Arun, Rajesh, yes.
So there is one thing that can happen.
Okay.
And is that a lot of them get some reaction when the anesthetist is giving it, an urticaria or something, or they feel uncomfortable. Then I only use the local.
Okay.
The local doesn't get absorbed and you get a...
So you give a local to everybody, or you give a local if they've had a problem previously?
No, I give local to everybody, but
Okay.
those who I can't give IV, I would probably use extra local.
But how do you know they can't get IV?
So the anesthetist starts off giving the IV.
Oh, if it starts out and it's a problem, I get it. Okay. Corticosteroid administration. Now, in the era of outpatient arthroplasty in North America, a lot of patients are getting corticosteroids perioperatively. Let me ask you what your practice is. Rajesh?
No.
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 Yes.
Yes.
No.
No.
Yes.
Yeah.
No, my spine colleagues are trying to convince me, but they haven't convinced me yet.
Yeah, Alpesh?
And, IV, no, we use interarticular,
Okay.
except diabetic.
Okay, so this is an area where practices evolve quite quickly. Intravenous steroids in a single dose definitely decrease postoperative nausea. There's quite a bit of data that says they decrease postoperative pain. Personally, I was always worried about the risk of infection, but so far in quite a few studies that has not emerged as a problem. So in North America, at least, with a lot of outpatient surgery being done, most patients are getting at least one dose of IV steroids around the time of surgery. Radiographs preoperatively, standard radiographs. A full-length hip film, hip to ankle film, or just 14 by 17-inch films? Rajesh? Excuse me, Sanjeev?
Standard X-rays.
Standard X-rays?
Standard access.
Scanograms.
Scanogram on everyone, Ashok?
Everyone.
Okay, Rajesh?
Normally standard X-rays. Currently, I'm doing the scanogram for some study that
Because you're doing a robotic study, probably.
Scanograms for all, pre and post.
And is that because you're worried about deformity that you can't see, or because you're doing robotics that needs it?
Even before robotics, we were doing it.
Okay.
For all scanograms, hip to ankle.
Okay.
All scanograms.
Okay, so about half the panels at least is getting a full-length hip-to-ankle film and using scanogram technology. Use of a tourniquet. Tourniquet for everyone, tourniquet just for exposure or cementation, or is there anybody you will never use a tourniquet on? Let's start, maybe let's start in the middle of the panel. Let's start with Arun.
I use it selectively.
Okay.
So if I'm doing a very obese patient, obviously I wouldn't use it.
Okay.
If there's any vascular problem, I wouldn't use it.
Otherwise, you'll use it most of the time?
And in a bilateral, I use it on one side.
Okay. All right, Rajesh.
So almost everyone, except for some of the contraindications, and I use it for exposure cementing. Once the cementing is done, I deflate
You'll let it down.
Get the, yeah.
Okay, Ashok?
I use it for all my patients except for those with vascular issues.
Okay, anybody else that grow dramatically different than the three speakers? Nope, pretty similar. Is anyone not using a tourniquet most of the time? It's interesting, in North America it got very popular not to use a tourniquet, and actually none of the data supports that approach. All the data shows that using a tourniquet is quite safe and doesn't really have major downsides, so except in the vascular path.
Then can you ask one
Yeah.
question to the panel?
Sure.
Whether they stopped using tourniquet and then have gone back to using tourniquet?
Okay, it's a great question. So let's ask that question. Did anybody stop using the tourniquet routinely and then go back to the tourniquet? 3 of you, 4 of you.
So I think it's very important because these patients have some medical comorbidities or hypertension and blood pressure. And if they're not regulated preoperatively a couple of weeks prior, then probably it's best to use a tourniquet.
Fair enough.
So I stopped it and then I come back.
Thanks. Rajesh, you brought up the question, so let me just very quickly ask you, why did you go back to using the tourniquet? You got tired of the blood?
So I think the benefits of not using the tourniquet
Hard to
in short,
quantitate.
except there's only one, and that the thigh pain in the first few days or maybe a week. But the discomfort of operating with that high blood in the field is much bigger, and therefore I've gone back.
So it's better for them to have a little pain than for you to have any pain. Just kidding. Sorry.
So we did a study where we were doing bilaterals and we were inflating them in both, and we found there was no difference except at 24 hours they could actively SLR when we didn't use the tourniquet, otherwise there was no difference.
Yeah,
So
most of the best data have failed to show any big advantage to not using a tourniquet, and for sure it makes your life easier as a surgeon. Routine exposure. Everybody doing median parapatellar? Anybody doing anything different? No.
I do subvastus approach for selected patients, lean and thin.
All right, one surgeon's doing subvastus, but most are using median parapatellar. All right, now we're going to get to it. Do you aim for neutral mechanical axis or something like kinematic alignment? How many, let's just raise their hands because there's going to be 100 answers to this question. How many of you shoot still for a neutral mechanical axis? That's interesting. Roughly 4 of you, 5 of you. How many of you are doing something else like kinematic alignment or functional alignment or something as a modification? Yes? 2 of you. Okay. Thank you. I'm not going to ask you exactly what you're doing because it's too complicated. Instrumentation. Manual, computer-assisted, robotic, which are in your standard vanilla knee, what are you doing most of the time? Starting with?
Computer-assisted and manual as well.
Okay.
Manual for the standard knees.
Okay.
I use manual instrumentation robotics only where there are implants or extra articular deformities.
Okay, so selective use of robotics.
So computer assisted for all at one center where I have all robotics.
Okay, Arun?
Computer assisted for all.
Okay, Parag?
Manual most of the times, but if my patient does insist he wants robotic, then I would do it reluctantly.
Okay, reluctantly, okay. Alpesh?
We use robotics and manual for selected patients.
Okay, great. We're going to have a big discussion about robotics later, so I won't ask more questions about that. Do you generally align your femoral rotation using some sort of anatomic landmark among the three that I've talked about, or do you generally do it by gap balancing? How many of you are gap balancers? How many of you are generally using mainly anatomic alignment methods for the rotation? So a little more on the anatomic than the gap balancing, and that would reflect pretty similar numbers to what's done in North America. I think we'll skip these two questions about balancing because there's several good talks coming up on the topic. How do you test flexion stability intraoperatively? Let me ask just a couple of the surgeons. First, Ashok, how do you do it?
Check stability in 30, 60, 90, and 120.
And how do you do it? You just pull the knee back and forth with trials in, or how do you do it?
Yes, so I have either my spacer blocks or my trials in place.
Okay.
And I'd like to, I want to make sure that it's about a 1 millimeter opening on the medial side, maybe 2 to 3 on the lateral side, across the range of movements.
Okay. Parag, how do you make sure the knee is not too loose in flexion? That's sort of the question here.
So the answer to that is I test it at about 90 degrees and 60 degrees, move it back and forth like a light.
With trials in place?
With trials.
Okay.
Yeah.
And the patella reduced?
Laterally, yes, with the patella reduced, definitely.
Any other tips from any panelists? Yes, Sanjeev.
Definitely ask very gentle lifting of the femur as well.
Okay.
So just see it.
So you'll distract the femur in flexion.
Yeah.
Rajesh, you had something to say?
I think when you assess that with the trial implants, it's a little bit late. And I like to assess it much earlier when your gaps are actually being constructed.
Sure, of course,
flexion
yeah.
and extension gaps.
Ideally, you will do it before, yes. That's an important point. And then you have to retest it again to make sure you got it right. Arun?
I use a tensioner to check this, the gaps both in extension and in flexion. Once my posterior cut has been made.
But do you trust that once you measure that's going to be good enough, or do you want a functional test afterwards?
Yeah, I also check it with the trials in place and put an osteotome, a curved osteotome, and try and lever it to see how much of gapping up.
That's a nice technique. The other one is just reduce the patella and physically test the AP stability.
Those using a technology, I don't think so there should be any problem checking it anyways. So you can do it.
If you're using technology, you know the data as it happens, right? Are any of you doing uncemented total knee arthroplasties?
No, not available in
It's
India.
not available, but I did a couple of femurs.
Okay. And Ashok, you're doing it? It's available?
Not all. We do it very selectively. We use the TM uncemented.
Okay. So most of you are using cemented technology still. In North America, there's a lot more uncemented knees being done now than there were in the past. It now represents about 20% of the total knees done in North America. We'll see what happens with that, but I mention it for interest. I think we'll skip this question. In most primary total knee arthroplasties, do you do a cruciate retaining, a PS knee with a post, some sort of ultra congruent bearing, or the latest flavor of the month, medial stabilized? Let's go down the list quickly.
I do CR knees always, and now I do CR attune RP.
Okay, a CR RP. Yep, okay.
I do PS with post, and depending upon the MRI finding and the PCL status, I can change for cruciate retaining also.
Okay, sometimes you'll do cruciate retaining, okay, Ashok?
Medial congruent always.
And you switched, is that right? Because you used to be a PS with a post.
I was CR.
Or you were CR, I'm sorry. Why did you switch from CR to medial stabilized?
Greater conformity, greater stability.
Okay, so you like the stability?
Yes, the stability is phenomenally good.
Okay, good. Raj?
PS with post, but I'll be quite happy if I get the medial stabilized.
But you can't get it yet?
I can't get it yet.
And if you get it, will you start using it?
I would
think?
just give it a go and see.
And see how you like it. Arun?
PS with post.
Okay.
As of today, PS with post, but after speaking to Ashok Rajgopal last night, I might change.
Okay.
I switched from PS to a medial congruent now.
Yeah, it's interesting. In North America, there's a lot of switching going on. Most of it's from PS with a post to medial stabilized. The CR people are generally sticking with the CR. Patella resurfacing, routinely, selectively, or never? Just a single word answer because we're short on time.
Never.
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 Routinely.
Always.
Always.
Never.
You see that there was exactly a 50-50 split there. and no room for anything in between. Antimicrobial irrigation with a antimicrobial agent after or as you close the wound. Yes or no?
No.
No?
Yes.
Yes.
After you close the wound, you're saying?
No, as you're closing.
Yeah, yes.
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 No.
We use Genta in the irrigation.
Okay, so 50-50 on that one too. Drains, yes or no? How many yes?
Yes.
Yes.
Only in revisions.
Okay, so it's interesting. In North America, most people aren't using drains much anymore with tranexamic acid, but some of you are still doing it. And I have to tell you that the data still has not been proven one way or the other on drains. So we'll wait and see about that. Do you give extended, that is more than 7 days, of oral antibiotics to patients who are at high risk for infection? If so, please raise your hand. Yes. So about 2/3 of the panel is yes on that. Do any of you do outpatient total knee arthroplasties in India yet?
No.
Not yet. It will probably come. Post-operative physical therapy, always? How many of you? Yes?
Always.
All of you.
Always.
Okay. Favored DVT prophylaxis. How many of you use aspirin routinely? How many of you use something else? Somebody else. Somebody, a few of you use something else.
High-risk patients, for high-risk patients.
High-risk patients, you'll use something else, of course. And here's our last question. Antibiotic prophylaxis. Do you recommend it for dental work or other, say, GI procedures? Yes or no? And if yes, do you do it forever or just for a limited period of time? Let's start at the end of the panel and work our way back this way.
We don't give it, and we don't have follow-up for that if they are having dental problems.
So you're not doing it, Alpesh?
Don't have a good answer, but if I have to use it for dental prophylaxis, it will be for up to 2 years maximum.
Okay.
We advise patients to have antibiotic prophylaxis.
Raj?
Advise always.
Always?
Always.
Always?
No.
No?
Always.
Always. So there was a discrepancy of opinion. What I'll tell you right now is in North America, most people, based on the data, have restricted it now to the first year or two after surgery and are not going forever. Maybe that's partly practicalities, but also some of it's based on the fact that there are not many late infections from dental procedures that you can trace for sure to a lack of an antibiotic. Ladies and gentlemen, I'm going to ask the panel to stay up here so that you can ask them questions afterwards. But first we have 2 talks, and then we'll allow you to ask some questions. So while we do that, please join me in thanking the panel for an outstanding set of discussions.